All right, it looks like several people have already joined. I'll give it just a few more seconds to see if anyone else is going to join us this afternoon. All right, welcome everyone. Thanks so much for joining us. I'm Kelly Mietnin, the Executive Director of ALD Connect. I'm excited to share that in 2022, the ALD Connect Board of Directors approved funding for this exciting collaborative multi-site research project called the Gray Zone. This is a community-wide initiative that explores important questions about genotype, biochemistry, and phenotype. So please feel free to submit questions either in the Q&A or in the chat, and we'll do our best to get those answered. Please note that this webinar is for informational purposes only. The discussion is not intended to be a substitute for professional medical advice, diagnosis, or treatment. If you or a family member are ill or suspect that you are ill, seek professional medical attention immediately. ALD Connect does not recommend or endorse any specific physicians, treatments, procedures, or products, even though they may be mentioned on this webinar. Now, it is my pleasure to introduce two of our board members and ALD experts. Dr. Stephan Kemp is an associate professor at Amsterdam University Medical Centers in the Netherlands, and Dr. Lund is an associate professor at the University of Minnesota. So with that, I'll turn it over to Dr. Kemp.
Thank you, Kelly. I'll share my screen, and then I think we'll just start directly. I'll move you all to the side, and I'll put my laser pointer in. Okay, today's webinar is about the gray zone. I'm sure many of you have heard about this gray zone, and it suddenly popped up last year. And it has to do with newborn screening and the diagnosis of ALD. And I'm doing this together with Lund. And we more or less decided that it's probably easiest if I just do a presentation and then we do a large Q&A session afterwards. And where are you? Yeah. Okay, so when we talk about ALD, I would like to start with the basics, with the genetics and the biochemistry. So if we talk about ALD, we're talking about a protein that's called the ABCD1 protein that resides in the cell. This is the cell, and in the cell you have all kinds of organelles like mitochondria, the nucleus, the ER, and this peroxisome. And the peroxisome is the site in the cell where the function of the ALD protein is important, because it has a function in the transport of very long chain fatty acids. This is the only place in the cell where these very long chain fatty acids can be broken down. And in case there is a mutation in the ABCD1 gene, this is the gene that codes for the ABCD1 protein. When there's a mutation in this gene, that results in a non-functional ABCD1 protein, and it cannot transport the very long chain fatty acids into the peroxisomes, and they're not broken down anymore. And as a result, or as a consequence, they build up. The levels build up in cells and in plasma and in tissues. And already in the 1970s, it was shown by Jim Powers that if you take an autopsy material and you look in these organs, you see these strange needle-like structures, and they should not be there. And that was the first clue to what's going on in ALD. And nowadays we know, well, actually since the 80s of last century, we know that we can diagnose ALD by measuring very long chain fatty acids. And nowadays we do this by C26 lyso-PC, which is a very long chain fatty acids, but to a complex lipid. And if you measure the C26 lyso-PC, it's elevated in all patients with ALD, so both males and females. I'll come back to that in a few slides. So there's a confirmatory test to test for when ALD is suspected, and that's in general that's when a patient presents at a doctor. There's some tests that can be done, and there's some facts. And the first fact is that all males with ALD have elevated plasma very long chain fatty acid levels, either very long chain fatty acid levels or the C26 lyso-PC. And if you measure the plasma very long chain fatty acids, that's a test that most of you have heard of, then this is sensitive for only 85% of females. So in case a woman is suspected to have ALD and the test comes back negative, then there's no guarantee that she doesn't have ALD. And since a few years, we also measure C26 lyso-Pc, and we've shown that if you do this test, the sensitivity is that it's elevated in 99% of females with ALD. And even many of the women that have normal plasma very long chain fatty acids levels will have C26 levels that are elevated. So the conclusion is that this C26 lyso-Pc measurement is a superior diagnostic marker. So you can do biochemistry, and you can also confirm with genetics. And another fact is that all ALD patients have a pathogenic variant or mutation in the ABCD1 gene. So the ABCD1 gene is the only gene that's responsible for ALD. And so we talk about pathogenic variants, then I think I need to explain a little bit more about genetics. So if we have a very simple scheme of the ALD protein, this is the protein that I just showed you before, this is the transporter of these very long chain fatty acids. It is built up of 745 building blocks, or also called amino acids. And if this would be the normal protein, this blue bar over here, then there can be several different genetic causes that have an effect on the protein. And so we have missense mutations or missense variants, and that means that one of the 745 building blocks is changed. So there's another building block. You can have nonsense mutations. That means that the protein stops here and the rest is just not there. You can have frame shifts. That means that at the site of the mutation, there's a different protein with very likely no good function is there. You can miss one of a few of these building blocks, or a large piece of it, so a large deletion. And all these different variants have clinical consequences. And for the nonsense, the frame shifts, the amino acid deletions, and the large deletions, they're all disease-causing. For amino acids, if they're very small, they are likely disease-causing, so we need additional proof. But for missense mutations or missense variants, when there's one building block changed, the clinical consequences is uncertain if there is no clinical proof of ALD. This is another way to look at the protein, also very schematic. So here are the 745 building blocks, here as little circles. And these are many of these missense variants. So where one building block is changed are plotted on the ALD protein. And we already have identified more than 500 different of these missense variants, and they're found all over the place. And you can see that there are green dots and there are red dots. The red dots are disease-causing, but there are also some changes in where an amino acid is changed for another amino acid, and it's not disease-causing. So these are referred to benign variants. So these changes do not affect the function of the protein, and they do not cause disease. So if we look at the protein, here's a skin cell, and I showed you the peroxisomes earlier on in the cell. And here we can visualize the protein by all these little punctate green dots. These are all peroxisomes in a single cell. And many of these mutations, they have an effect on the protein, and the punctate staining is lost. So you don't see in this is a cell line in which there's a mutation. You don't see this punctate staining anymore, and you see some kind of a green glare in the cell. And that's a clue that the genetic change is pathogenic, because the protein is just gone. So I mentioned that we have a mutation in the ABCD1 gene, a pathogenic variant that results in elevated levels of very long chain fatty acids, or C26 lyso-Pc, and we can establish already at birth. So that's this. So you can do newborn screening for ALD. So that's a given fact. But you see these three arrows. If we know the variant and we know that the very long chain fatty acids are elevated, we cannot predict the clinical outcome of an individual. And that's problematic, because there are basically three core syndromes for ALD. Before the age of 10 years, 1 out of 2 boys will develop adrenal disease, and it can be already as early as 6 months of age, and that can be treated with hormone replacement therapy. And before the age of 10 years, 1 out of 3 boys will develop cerebral ALD, and if that is diagnosed in time, that can be treated with a bone marrow transplant. But not all males will develop either adrenal insufficiency or cerebral ALD. But we cannot predict that. So currently, all males that are diagnosed with ALD have been followed very rigorously to see whether this starts adrenal insufficiency or cerebral ALD. So back to the mutations. So I mentioned the missense mutations a few times now, where there's one building block has changed and the clinical consequence is uncertain. And I also mentioned that we have many of these have been identified, and basically all variants that are identified in the ALD gene, as long as if they're shared with the scientific literature or with us, they are registered in the ABCD1 variant database, which is part of the ALD.info. And by now, already more than 1,000 different pathogenic variants are registered in the database, and this is freely accessible, so everybody can just go there and look at the different variants. And if we now look at the missense variants, we see that from the 532 variants, we have over 200 pathogenic, so proven pathogenic variants. We have 150 that are likely pathogenic, so we still need some more proof. But we also have over 100 variants of uncertain significance. And as I mentioned, there are also some benign variants, so changes in the protein that do not affect and do not cause disease. But there are more than 100 variants of uncertain significance. And what is clear is that if a variant of uncertain significance is found in an individual and there is no disease present already, that this causes a diagnostic uncertainty. The question is this another benign variant, or is this a pathogenic variant? And if there are no clinical clues, you cannot comment on that. And if we talk about diagnostics, it's important to realize that there are 2 different ways of diagnostic testing. So before newborn screening started, in general, when a clinically ill patient visited the doctor and there was a suspicion of a disease, you could take a blood sample and send it to the lab and perform confirmatory testing. But now with population screening, this is a very different situation, because in this case, in population screening, healthy individuals are screened to detect disease before clinical signs are present. And that's a very different situation. As I said, so before a patient visits the doctor, this may be ALD, take a blood sample, send it to the lab, measure the C26 live GPC and do DNA analysis. If the fatty acids are elevated and if there's a pathogenic variant in the ALD gene, it's ALD. But that's not the case for the population screening. And it's important to realize that the results from many diagnostic tests are not binary. It's not 0 or 1, yes or no. So they're not simply positive or negative. Often it's a continuous range of results. It can go from 0 to 100 and everything in between. So if we visualize that, then we have here in green, we have the control range. And in blue, we have the clinically affected range. So when the patient visits the doctor and it is an ALD case, then in general, the results will be in this blue area. If it's not ALD, then in general, the results will be in the green area. But you can also see that in the middle, there's sometimes these regions overlap and sometimes they don't overlap. And we refer to what is in the middle, we refer to this as the gray zone. So now this is what happens in newborn screening. So all newborns are screened for ALD, and you will find measurements. And in general, these measurements will either be in the green area, in the control range, or they will be in the blue area, in the ALD range. And in this case, it's not so difficult, because either the child is unaffected or the child is affected. The problem starts when there is a measurement in the gray zone. We do not know if this orange dot technically belongs to the blue zone or to the green zone. So in these cases, there is a dilemma. And the question you may ask is, why do we find these values in the gray zone? Why do we not just find values that are in the green zone or in the blue zone? Well, I mentioned that there are genetic variants in the protein, and sometimes a building block is changed and it does not affect the protein. But you can also imagine that sometimes that there may be changes in the protein that do have an effect on the protein. And that gives rise to maybe the protein be a little less active. And as a consequence, the C20 lysis PC levels will be above the control range, but maybe they are below the disease range. And of course, the big question is this now a disease-causing or a pathogenic variant, or is it a benign variant? And these variants we call a variant of uncertain significance, because simply we have no idea if they're pathogenic or benign. And why is this now why is thus a diagnostic dilemma? Well, in general, when there are no clinical clues. So when we're talking about newborn screening, babies with ALD are always healthy. They don't have signs or symptoms of ALD, because the disease doesn't start before the baby is a few months old, or much later for adrenal disease, or the age of 3 years, or later for cerebral ALD. And because there's no family history, and the variant is most often not previously reported, or it has been reported, but it's also in a newborn. And so the big question is this disease causing? So back to the table that I showed with the 103 variants. And it's interesting to note that these variants of uncertain significance, almost all of them have been identified through newborn screening. Some of them have been identified to diagnostic commercial tests that are performed by commercial companies, or by whole exome sequencing. When there is a patient, it's not really clear what kind of disease there is, and then you can do mass genomic screening, and that we call whole exome sequencing. So all these viruses have been identified in individuals that did not have clinical signs or symptoms of ALD. So what happens when there's a positive newborn screening result? So in the current situation, so as I mentioned, there's no test yet to assess whether the boy will truly develop ALD. So currently, all boys are subjected to the same rigorous follow-up protocol. That means that from the age of 6 months onwards, and then every 6 months, the adrenal function will be tested. And starting at the age of 2 years, every 6 months, the boy will receive an MRI. And of course, this will have significant psychological effect on the affected families, because they don't know if their child will have ALD, yes or no. And of course, it will also be very helpful if we would be able to predict what kind of clinical outcome the boy would develop. And when we talk about viruses, I would like to give 2 examples. So this is an arginine 482 glutamine. So it was identified 8 times already in newborn screening programs in New York, California, Pennsylvania, Texas, and also in the Netherlands. And because it has never been associated with a patient, it's classified as a variant of uncertain significance. There's no supporting biochemical or clinical data. We performed some functional testing in fibroblasts, and it showed that the variant does have an effect on the ALD protein, but it's not really clear if it's not the same effect as we see in established patients. So none of the families reported a history of ALD, There was in one family there was an indication of an unexplained neuropathy in a male over the age of 60 years, but the male had passed away, so it could not be tested if that was ALD related. But the big question is, the ALD gene was identified in 1993, and we've been collecting pathogenic variants since that time. And the simple question is, why did we never see this variant in a clinically affected ALD patients? So between 1993 and 2022, and now suddenly, when newborn screening is expanded, we see it more than 9 times already since 2018. Another example is lysine 533 glutamine. This by now has been identified 11 times in newborn screening in different states. It's also been identified in genomic screens in the United States, in Germany, and in Israel. Also, this variant has been classified as a variant of uncertain significance. And also, when we performed functional studies in this cell lines with this variant, we do see that it does have an effect on the protein, but it's not really clear yet if it's to the same extent as in proven ALD patients. And again, none of these families have reported a history of ALD. Also, when we do extended family screening, adult males have been identified with this variant, but when they are seen by a doctor and an ALD expert, they don't have signs of ALD. And when the plasma variant acids are measured, they are in the gray zone, or they're just above the upper limit of reference range. And again, the same question, why did we never see this variant before newborn screening started, and now it's been identified more than 10 times already? Is this unique for ALD, the identification of fuses when you do population screening? No, actually it's not. We do see it in other diseases, in lysosomal storage diseases, in mitochondrial diseases, basically in all diseases that are included in newborn screening programs. And it's not just in newborn screening programs, it's also when population screening is done for high cholesterol or for breast cancer. About 20% of the genetic tests come back with a variant of uncertain significance. And these are all titles from publications from the last year and a half. So this is becoming actually a big problem in many disease programs, because there are now many reports on the effect of these diagnostic dilemmas and psychological effects that it has to families. In ALD newborn screening, we already identified more than 100 fuses in the ABCD1 gene. And yeah, well, I'm repeating myself here. The big question is, are these pathogenic or are these benign, or are these late onset forms that we also didn't see before newborn screening? It is possible that there are patients out there that have late onset ALD related phenotypes that simply never were diagnosed with ALD, and maybe some of these variants are causing these kind of symptoms. But in the current situation, when a screen positive results come back, there is an ABCD1 variant, the boy is referred to a medical specialist. There's diagnostic uncertainty, but all the boys are subjected to the same rigorous follow-up protocol. It is costly, it causes a lot of anxiety with families. And some of these newborns, they are in the gray zone. And the big question is, are these boys at risk for developing adrenal disease or cerebral ALD? Or are they at risk of developing a late onset or mild form of ALD? And should their follow-up protocol then be changed? Do they benefit from an MRI every 6 months? We don't know, and we cannot answer these questions yet. Or do some of these newborns don't have ALD? And are we creating patients? And so this has to be resolved, because if you find too many versus in a newborn screening program, eventually it may be that states say, well, this is not productive. This program is not productive anymore. And so there's always a danger of that there may be consequences to a screening project. So yeah, action is required because if you have too many too high false positive rates in newborn screening, it causes parental stress, anxiety. It has an effect on increased health care costs because you may do a lot of unnecessary medical procedures. There is a financial burden on families because many additional tests and treatments, specifically tests, are employed, and they're not always covered by insurance. Medical harm. If you do unnecessary medical procedures, there's medical harm. And eventually there's the risk of reduced trust in screening programs, as I mentioned. Action again. So we last year we started working on this, and luckily the ALD Connect is funding a small pilot study in which we can set up a system to tackle this problem. And together with Josh Bukowski, Troy Lund, and myself, we are now starting this pilot study, referred to as the gray zone. And we started with making an inventory of all the fusses that are out there. For me, that was not very hard because I'm curating the ABCD1 variant database, and especially the last 2 years, maybe 3 years, I'm more and more approached by emails from families coming to me with, we have this variant and it's referred to as a variant of uncertain significance, and I start adding all these in the tables, and so we have more than 100 now, and also we do know where they come from. We are in contact with the treating physicians, and now I think we're in a situation that we can start working on this, because we have 2 facts in ALD. I mentioned it already a few times. All males with ALD have elevated C26 levels, and all ALD patients who have a pathogenic variant in the ABCD1 gene. And we can work with these 2 facts. So what we will do, if a newborn is identified with a FUS and result in the gray zone, we have to perform extended family screening, and often with genetic testing, adult males will be identified with the same variant. Well, if these adult males have the same variant and they have ALD, their C26 levels should be elevated, because that's one of the facts. So what happens is that an ALD specialist will perform a clinical exam and collect samples, in general blood, so we can do C26 measurements in plasma, and if needed, skin biopsy, so we can generate cell lines. And so the blood is drawn, the tube is centrifuged, and then you get this upper yellow layer that's called plasma. That's big in several tubes. It's collected and it's stored in the -70 freezer. And also from the blood itself, we do a little bit of blood so that we can isolate DNA for genetic testing. And then some of these tubes they stay at the Home Institute because if in case something goes wrong with the shipment. And part of the tubes are shipped to a central site in the US or directly to Amsterdam. So when they come to Amsterdam, because my research group is part of the laboratory genetic metabolic diseases, and the lab genetic metabolic diseases has been performing diagnostic testing for paroxysmal diseases and ALD since the 80s. So we have, and we switched from plasma variant chain reactions to C26 lighter PC for newborns and patients. And other paroxysmal diseases already several years ago. So we have really good established control and disease ranges, because these green ones at the bottom are over 1,200 controls, and the blue ones are over 150 males with ALD. And as I said, if there's a skin biopsy, we can grow culture fibroblasts, and we can perform functional testing. So we can question the ALD protein, its function, and we can compare that to normal cells and to cells from ALD patients and see where the level in this FUS cell line is. In the plasma, we would like to have plasma from 3 to 5 adults with the same variant, and then the plasma is generated, and in the plasma we measure C20 lyso PC, and these values we can compare to our reference reagents in the lab, and we also perform lipidomics. And lipidomics is a technique where you look at all complex lipids and to the fatty acids that are attached to it. And we've been doing this, and we will publish, hope to publish a paper in a few months, in which we have next to C20 lyso PC many more complex lipids that are highly elevated in ALD. And so we do this for established ALD patients, for controls, and we also would like to include the individuals with us to see where they are on the in these analyses. And yeah, what are the expected outcomes? Well, the ultimate goal is, of course, is to resolve all the diagnostic uncertainty for all VUSs. I think that we should put the bar high, and we should say, well, there should not be no families should be out there with a diagnostic uncertainty. And in the pilots, so in the first year, we will collect clinical, radiological, laboratory, and patient samples from 10 or preferably more different ABCD1 variants, so different VUSs. In plasma, we will reanalyze the C20 lyso PC. It's important to realize that we like to do everything over in Amsterdam, so we will not deal with data that is done by other labs or commercial labs. We have to do this again because these are all different techniques, and you have to use the one and the same technique to make good comparisons. Well, like I said, we do the functional assays in skin fibroblasts to see what the effect is of the variant is on the ABCD1's protein function, and maybe in the event we can also define a new cutoff for this test. So we're already working on this, and yeah, of course, it would be very nice if we could develop a continuous test pipeline. So as soon as a new plasma sample comes in, that we just measure it and add it to the growing amount of data that we have. So that we don't have to do this in groups. The goal in the first year is that we will resolve at least 5 different VUSs. But of course, that depends on how soon can we get the plasma samples from the families. Because that is a logistical challenge, I came to realize over the last few months. And of course, we will share all the information that we get with the treating physicians, the families, the states, and the countries, because we also have we have annual meetings where we share information and where states are present, and of course, this information has to be shared. But I think the best and easiest way to share it is to report it on the ABCD1 variant database, because that's publicly freely accessible, so everybody can look at it. Yeah, and that's my last slide, the acknowledgements, and I'm not going to name patient individuals here because this truly is a worldwide ALD community project. And of course, I would like to thank ALD Connect for starting with the funding of the pilot. And I think that, yeah, and of course, there's the sponsor page, but I think Kelly will mention it also. This is a big project, because I would not like to stop after 1 year, and I think this is a project that will go on for a few years, and there are many more things that we can do with. And I think I should just now stop sharing.
Thank you, Dr. Kemp. We have several questions for you and Dr. Lund. So the first one is, how do I know if my family is in the gray zone?
That's an excellent question. That's an excellent question. It's also a very difficult question because I also don't know the screening results. I think the simplest answer is that, well, also be honest, I don't know if your family is in the gray zone, but if your family has a FUS, that already qualifies for the gray zone project. So the gray zone project is not limited to measurements in the gray zone, because they are with different techniques, and often there is no gray zone. A commercial lab, that's a good. A commercial lab doesn't have a gray zone, because a commercial lab doesn't have access to patients. So they only have they can run 1,000 controls, and so they have an upper limit of control. And basically everything that's above that, that's where the gray zone starts. So you can only limit the gray zone if you have a lot of ALD patients, because then you can generate this blue zone above the green one. Always good to work with colors.
Yes. So there are no levels that would put you in the gray zone for VLCFAs. Is that correct?
If you would measure it at Kennedy Krieger or at the Mayo or in Amsterdam, then I said yes, there are levels in the gray zone, because they're falling between the lower part of the blue zone, so the LD zone, and they are above the green zone. But for commercial labs, yeah, they're elevated. Yeah,
Okay.
they're elevated. Yeah, what does it mean, elevated? Please add, Troy, if you think he's not making any sense.
What can I add to make more sense of it? I think the gray zone is defined by family history, not by a level necessarily. So if there's a diagnosis in a family of a mutation and other family members find these mutations, but there's 0 persons with AMN, with adrenal insufficiency, with no history of ALD, I would put you in the gray zone.
Yeah.
For that reason, it's really those families that I speak with that we're trying to figure out. And if the mutation or VUS or whatever you want to call it has never been reported associated with cerebral disease, that by definition is gray zone too.
Yeah.
If I see a family in clinic and we find a mutation and it's in Dr. Kemp's mutation database and it says 12 individuals with cerebral disease, that is not the gray zone.
Nope.
No, it's the opposite of that. It's when we don't find anybody, even though we're dealing with an ABCD1, mutation or VUS or base pair change or whatever you want to call it.
Yeah. So basically, if you find something new, if you find something new, it comes back from the lab, a variant of uncertain significant. It means that the person sending it back to you, the report, has no clue.
Right. And these new,
that's pretty gray.
Yeah, these new mutations, these new ones, sometimes the very long chain fatty acids are high. Sometimes they're kind of high. Sometimes they're just on the upper end of normal. Yep. And sometimes they're still cold normal. And that's really the puzzling part and really what's at the heart of the gray zone, is trying to figure all that out.
All right. Next question is, can a patient with adrenal insufficiency be in the gray zone?
Nope.
I don't think so, because if you have adrenal insufficiency, your adrenal gland has already succumbed to the elevations in very long chain fatty acids. It does not set you up to automatically develop AMN or cerebral disease, but we know at least it is that mutation is causing disease of the adrenal gland. So you are affected, at least your adrenal glands are.
Yeah, so this question also comes back to, can we predict the clinical outcome of an individual? And that's a different question. And I said, well, this is not a 1-year project that we want to go on, because of course we want to resolve the fusses, but we also, of course, the holy grail is that we can predict. That we can predict from a young boy, okay, you are at risk of developing cerebral ALD. Because this is a difficult topic, but if you really can do that, then of course your whole follow-up and management, disease management of boys will be different. It can be more relaxed if they're at low risk, or it must be more strength, or when they're at high risk, or maybe preventative, or I don't know. But that's the next. Well,
Phase 2.
yeah, they go together, but next level.
All right. So a couple of questions that are sort of related here. Will this work to help predict a person's outcome? So cerebral ALD, AMN, based on what variant you have. Related question is, if so, if you know that a variant is going to result in cerebral ALD, would you intervene early before a lesion with a bone marrow transplant or gene therapy?
That's for you.
Yeah, I think, well, in a perfect world, if it was the perfect test and perfectly 100% predictable, you certainly could and would do that. I don't know if we'll get to 100% because the procedure methodology of either bone marrow transplant or gene therapy is a very serious undertaking. And so you'd have to be for certain on the order of 1 in 1,000 or even more that the child was getting cerebral disease. So, that would be the ultimate goal, but I don't know if we'll be able to get to that kind of precision. So for now, we will have to rely on MRIs.
All right. Can you go over again the difference between the two biochemical tests for ALD and explain why the C26 lyso-PC test is more sensitive for women? Dr. Kemp?
Yeah, the honest answer is that I don't really know why the variant chain fatty acids can be normal in a woman and the C26 lyso-PC is elevated. But it probably has to do with the fact that the C26 molecule itself, the fatty acid, it sticks to a lot of lipids, a lot of fatty acids, a lot of lipids, and we don't really know to how many and in what extent. So I can only turn it around when we measure C26 lyso-PC and we say, well, what does it look like in women with ALD and normal plasma variant chain fatty acids, because those are the tricky ones. Then we see that in the women with normal plasma variant chain fatty acids, they are elevated. So why that is, we don't really know, but that it is like that we do know. That's one of the big reasons. Well, that's one of the reasons that the lab in Amsterdam shifted to measure C26 lyso-PC already 3 years ago. It's faster. It's also a little cheaper. You can do more samples at the same time. It's more high throughput, and it's much more sensitive.
All right. Is there a list of variants that you're studying?
I have a list of variants that I'm studying. Yes.
Are you willing to share it?
No, we wanna study as many as possible, and I get the question often, and I say, well, it's not first come first serve, but it's I have my list of favorites, but it depends on access. So it depends on is the family is there extended family screening? Are there males in the family that have the same variants? Are they willing to donate blood? Is there a physician in the area who wants to look at these males? Because we really want to know that they don't have ALD, or maybe they have late onset signs, and that's also important. Because we can expect that that in any disease, the better you look, the broader the spectrum becomes. So I'm pretty sure that the mildest form of ALD is now old males, aged males, with mild spinal cord effect, no adrenal disease. But I'm pretty sure that if we look better, there will be even the spectrum continues. It is very well possible that these phenotypes that you only see in advanced aged males, that these are associated with some of these vessels. So it depends. So we need a clinician, we need the family, we need the logistics, and I said it a little, made a very short sentence about it. I came to learn that it's very challenging to get samples from one place to the other place. It's also costlier because plasma samples have to be sent on dry ice. That's right.
Oh, yes.
So yeah, if you don't want to send every single plasma by FedEx, packets get lost. So you don't want to send every single sample from California, from Minnesota, from where to Amsterdam. So we're trying to figure out a way of central sites in the US that they can send to, and then we send them in bulk. And then we also have some few spare tubes in Troy's lab or with Josh. So in case the package got lost, because you don't want to go back to the individuals and draw blood again. So do I have a list of preferences? Yeah, well, maybe not. But yeah, like I said, it depends on so many other factors.
Can you talk a little bit more about the samples? So there's a question about fibroblasts. What are they, and how can people send samples to you? How many do you need? How many samples from each family do you require? Maybe just talk a little bit more about that part of the process.
Yeah, I know about fibroblasts. I think Troy, he probably takes biopsies. So
yeah, that's so the skin samples are through a punch biopsy, about 2 to 3 millimeters in diameter, so something pretty small. We put it in a jar and save it, and then we grow cells out of it. For the person, we usually use local lidocaine, numb up the skin, and then put 2 stitches in, and then it's healed within about 10 days after that. Really no pain associated with it, really no bleeding associated with it. It's pretty benign process. So that's how we handle the skin, and that becomes a very important sample actually for Dr. Kemp to work on, because it gives us some cells and substrate that we can grow and work on biochemically. And then the blood samples are just blood draws, standard blood draws, so nothing to explain there. So, but that's skin and blood. It's certainly blood we can get on pretty much everybody of any age. Skin samples are a little bit harder to come by for people to volunteer to do it, but nevertheless are very important.
What is the
yeah.
update? Sorry, Dr. Kemp.
No, go ahead.
What is the updated incidence of ALD now that we've been screening in so many states? Do you know?
That's a very good question, and I have seen it's all over the place. But I think that I think that the numbers from New York State are still 1 in 15,000, and some states report higher. But it also depends on how many newborns you already screened. To give an example, in the Netherlands we screened 36,000 boys. And for 1 year, and in November we had only found 1, and then in 1 week we found 3. So our incidence went so eventually you come to the true incidence. And also what another important thing is that are states counting VUSs? Because technically a VUS you should not add to the incidence, because you don't know if it's ALD. So so in the perfect world you would only count individuals that have disease or have a pathogenic variant, because there is a fair chance that there are some boys out there that are now in the calculation that may not have ALD. But let's stick to 1 in 15,000.
Next question. Are you noticing the same variations among family members? I've always been told just because previous family members may have cerebral ALD, that doesn't mean her son will have cerebral. Dr. Lund?
Very well. So there's no difference. There's no variations in the genotype amongst family members. So it's a disease we call it has a private mutation. So most of the time, every family has their own mutation. Occasionally, you can find families separated geographically that have the same mutation, or even, let's just say, kindreds of families in different states that have the same mutation that maybe turned out to be related multiple generations back and didn't know it. But within a family, there's no genetic variation.
Okay.
Maybe I can add to this answer, because I think the question is also if we know, maybe not a question, but then I'm answering a question that was not asked.
It's okay.
I tend to do that. So I think also the question comes down to do these mutations have predictive value? And in general, no. In general, not. And that's because what we do know is that there are other genes, other factors out there. So in order to develop ALD, you must have a pathogenic variant in the ABCD1 gene. And then you develop ALD. And it looks like, correct me if I'm wrong, Troy, but it looks like that the default mode of ALD is spinal cord disease. And maybe adrenal disease. And there are other factors out there, and we're looking for those. So genetic factors in other genes, inflammatory genes, other genes that have an effect on fatty acid levels, and these participate on the ALD defect and cause cerebral ALD. And that's also why it is so difficult, and there's no predictive value in the variant because of these other factors. And we're looking for those. There have been many studies have been done. Sometimes they were found, and then they were tested in an other patient cohort, and they were not there. They were not there anymore. And we only have one. We identified one gene that seems to hold up, that is a little bit more prevalent in cerebral ALD, and that is a gene that is only expressed in the brain, and it has to do with inflammatory components. So that is another very big research line that a lot of groups are working on. What is causing cerebral ALD? I see you nodding, Troy, so I guess you agree?
Yep, I agree. Yeah, we still don't, we just frankly don't know. Same variant through families, within families, can have totally different outcomes. So we're just not quite there yet. So.
All right. Have you seen any buses be reclassified to pathogenic?
Yeah. That's one of my biggest important roles in maintaining the ABCD1 variant database, because I receive a notification that a new variant has been identified in newborn screening. So by definition, it's a FUS, because there's no clinical proof. It has been identified in ALD newborn screening. So I put it in there, and I say, well, this is a variant of uncertain significance because it's identified in newborn screening, and there's a reference to the lab or the state. So now if Troy contacts me and he says, I have this AMN mill and elevated variant fatty acids, and this is the genetic variant, and it's the same variant as that VUS. So then we have a VUS that was reported in newborn screening, and we have the same variant that's associated with disease. So then we can reclassify the VAS, and then it goes from variant of uncertain significance to likely pathogenic. Because if there's only one individual, we have to be a little cautious. So we say if there's only one, we go from likely. If now Josh or Ali Fatimi or Florian Eichler contacts me and said, I have this family and they happen to have the same variant, and there are males in there with adrenal insufficiency, then we move to pathogenic. Because we connect things. So in that way we can do that.
So Dr. Kemp, how can the community get their information added to the database?
They contact me. I started a reference number because everything has a reference number, and I started a reference information provided by families because I got so much information. And yeah, I can say, well, I only can add stuff that I get from publications or from diagnostic labs. But if a family contacts me and I have, it's clear that there is ALD in the family and there's a lot of why should I not add it?
So you'll add any information, not just the buses, correct?
Yeah, and even if the variant is already in there. Because if it's the power of the numbers, so if a variant is reported one time, or two times, or three times, or four times, or five times, the more, well, eventually it is clear. But if it's reported multiple times, then it's really clear that it becomes pathogenic, and that of course that helps when that variant is then identified in newborn screening. People go to the database, say, hey, this I identified, like Troy already mentioned it 10 minutes ago. He goes to the database, hey, this has been reported 12 times. Okay, this is pathogenic. So the system helps us, so everybody helps everybody.
Okay, there was a question or a comment, I guess, that someone knows their family member has cerebral. So how can this help other patients? So I think you answered that question by explaining how it all works together.
Yeah.
Are there known variants that the probable outcome of the disease known?
Not yet, no.
Yeah, not really.
So for Dr. Lund, how would this information change your surveillance of patients?
I would make the surveillance more patient specific if I knew the risk was lower. So to simply put it, it would be nice to take the variants of unknown significance and move them into the category of variant of no significance. Right, that would be a big benefit to us in the field, because then I can move patients from standard surveillance into very low level surveillance, or no surveillance if we were really convinced. And I'm sure that'll happen. I'm sure we'll figure some of those variants out. There's just too many, and we don't see as much cerebral disease as we do variants. So.
Dr. Kemp, how much money do you need to complete this project?
It's a very American question. And as Europeans, so we already...
I didn't ask it.
You did no. So this has been asked to me in the past. So we have a lot of good science, and we have a lot of good ideas, and we have a lot of good plans, but we just don't have enough people to do it. So if you really want to ask, how can I help? Yeah, if we could hire another PhD student for 4 years, so that will be $250,000. So the dollar and the euro are now more or less the same. We could cover salary for 4 years, and then we have somebody who can work dedicated on these projects. So yeah. And if you're 2 students, that will even be better. But yeah, there's so many projects that are going on. and it's becomes me, Troy, I, others, we are always looking for funding with agencies and projects, and we write grants, and we beautiful grants, and then the chance of success is between 5 and 15%. You put your whole life in the piece of paper, and you say, okay, this is going to be the one. This is going to be the one, and then it's a great pay, it's a great grant, but unfortunately, yeah. So the good thing is that you keep working on your plans and making it better and better. But the guarantee that you get the money is not very large. So by now we have so many good stuff, and we're ready to go. We have good international collaborations, and that really helps a lot. I know that what Troy is good at, so I'm not going to repeat it. We do it together, and the same with Joyce, with Florian, with Ali, and I think that's a strong and I think unique thing in the ALD community is that many of the PIs in the groups, in the research groups, also Johannes Berger in Vienna, we know each other for, well, at least 15 years, longer. And yeah, we trust each other, and we like working together with each other. And I think that really helps in moving forward. There's hardly any competition.
Great. So we're about at time. I just want to summarize for everyone who's listening what the process is. So if people are wondering if they're in the gray zone, how they should contact the research team and what they should do, what's most important.
Yeah, good question. If you can contact me directly, that happens. We have a protocol for drawing blood, and sometimes it is important that there is a physician out there that can help with drawing blood, and the blood has to be centrifuged, so plasma has to be separated. So a diagnostic lab or anything that can help would be great. A funny thing is that I keep saying that's funny. It's not so funny, but it's interesting thing is that sometimes it's maybe even cheaper to fly to Minnesota and get your blood drawn over there. I don't know. I'm just throwing this in here, Troy. So I know all planes coming to you, but
Yeah.
So it is very hard to say because it depends on the environment, the resources that are there to help. So if families are already seeing Keith or Troy or Joyce, yeah, then it's fairly easy with your annual checkup. Get the blood and make sure that they save plasma samples.
Dr. Lund, any comments on that question?
Yeah, it's without being at a center, it can be a little tricky. You'd have to, I could tell a family how to do it, go into the physician or lab and draw a 10 cc purple top tube of blood, put it on some cold packs and FedEx it to me. It would probably be fine if you do it overnight. Like it's easy to say that, but it's I think daunting for some families to do it, but that's really all you have to do. And then we'll process it. So that's, if that can be done, it's easy.
But it has to be it has to arrive in time. Otherwise, if the blood is how do you call it, hemolyzed?
No, if you put it on cold packs, it can go anywhere from New York to LA. So maybe we should, Stephan, maybe we should develop maybe a protocol for families to do it themselves if they are so motivated, and we could just put that online.
Okay.
All right, because everybody has access to cold packs. They're available at Walmart. Everybody has access to a foam cooler. It's not hard.
Yeah.
You just pack it and
but someone needs to put a needle in the vein. Huh?
Yes, that would have to be done at the doctor's office. So for sure, that would be at the doctor's office or their laboratory, but then they would just have to hand them the 10 cc tube of blood.
Yeah.
All right. We'll work on figuring that out.
Yeah.
A couple more questions. Is it okay if we put your contact information in the chat?
Who,
Okay,
mine?
everyone.
Yeah, oh yeah, I'm on the database, so I'm everywhere. So
All right, we'll have Felicity drop it in there for everyone. We'll make sure it gets posted. Any last thoughts from either of you?
No, I think we do that again in a few months.
Yeah, we look forward to an update. Thanks everyone for joining. If you are interested in supporting this project, we do have a link on our website so you can donate directly to support the Gray Zone. We appreciate those donations very much. And we look forward to keeping everyone updated as this project progresses. So thanks so much.
Yeah.
You're welcome.
Bye-bye. Thank you.